I tacked everything onto it. It's all in the same
when you ask them
email.
how they're doing.
Yesterday one?
They would say,
All the files are
fine, just fine, because you would never say that. And then over a period of time, they would introduce the fact that you've been like, and then you may say, you know, that you've been
I'm gonna work on it.
robbed and everything else in the world, but you wouldn't remember that, because you'd be fine.
Yeah, I'll do that.
You know, it's interesting that because in England, we say something that's quite good, it means it's really bad. You say, yeah, be super careful. But in America, it means it's pretty good, you know? Quite good is like horrendous in England. And I learned that the hard way from this.
Nobody's sitting up front.
Oh my goodness.
Because they don't have, then that means you don't like it. No, it's not so bad. They just mean, oh, that's pretty bad for
Exactly. Whereas in America, if someone says, how are you doing, they really don't want to know. It's just a salutation. Exactly. If you take it seriously and tell them, it's like, well, why is the person talking?
Yeah.
My wife showed me
Lots of spaces up in the front.
from South Africa. So the documentary movie about the Marching Band that feels like this.
Which is going to be
And Cheryl's going to be here
We
late
have
for the
to see
I know we have a couple people who can't wait
John
for it.
probably heard this. She's on the news and I'm going to it's a little bit awful, though it's a school.
Okay, good afternoon, everyone. Thank you so much for coming, and a special thanks to the Duke Global Health Institute for coordinating and publicizing and supporting this event. My name is Nikki, and I am working on a project in Kenya with Dr. Sarah Benjamin Nealon's team, and I have the privilege of introducing our collaborator in Kenya, Professor David Nagetai. He is the founder and director of the Africa Mental Health Foundation and professor of psychiatry at the University of Nairobi. And his specialties are in psychotherapy and mental health. And he told me yesterday he's trained 95 psychiatrists in Kenya. So please join me in welcoming him as he gives his talk on global mental health in Africa.
Thank you very much for that wonderful introduction, and thank you very much for coming to listen to me. I had a pleasant surprise this morning as I was being taken around. I met a young man there who insisted that he was my student. Because of Nairobi. And when he gave me more details, I realized as a matter of fact we have done some work together.
Wow.
And I'm so happy that I met him here, and he's pursuing his academic and hopefully research career. And I hope that his stay here will be a big blessing to all of us in terms of the research and the future of research in Africa. That is the topic of my presentation. Hope for mental health for all in Africa. I'm saying home because I believe that we now know quite a bit on the way forward in terms of mental health in Africa and what we can do. Of course, there are challenges and opportunities and working together. When I say working together, I am talking about the working together in Kenya, tapping on all the resources, and tapping on the resources from the global arena. I'm sure we can do something. That's what I do. And if you miss anything on what I'm going to do, just go back to that website. There's a lot of information about me and the foundation which I run. That's Kenya, on the eastern coast of Africa. And on the left is Maasai. Maasais are really very courageous people, and if you hear me out, they are known for killing lions with their hands and a stick. Sometimes they can stand on one leg for hours on end. A lion, when you come to Kenya, you see lions next door. Where I live, we are always around near our homes and the beach. One of my neighbors is actually an American from California, and he's doing quite a lot in terms of conserving wildlife in Kenya. This is the foundation where I work, which we acquired recently, very near town, and just behind the British High Commission and the Minister of Health. These are some of my staff. In fact, this is just a fraction of the staff that are working in the African Health Foundation. So let me go to the main part of my speech, my presentation, and highlight one or two things, and then we can go into the new challenges that we have. All the indication from the available epidemiological data suggests that the patterns and the prevalences of mental disorders in Africa are similar to those found in high-income countries, such as this country where we are. The most important thing is that apart from this similarity, everything else is different. We have a lack of highly skilled human resources in low middle-income countries. One psychiatrist for more than 1 million people in most of South African countries outside South Africa. Kenya, however, like for example, Nigeria with a population of about 150 million, maybe slightly more than that, we have 150 psychiatrists. Ethiopia, our neighbor on the north, they have a population of about 90 million. We have 47 psychiatrists. Our next door neighbor, Uganda, with about 3 million, we have 30 psychiatrists. On our immediate neighbor on the right, Somalia, they don't have any. The population is thought to be about 6 to 10 million. Tanzania, with a population of about 42 million, we have about less than 30 million, and so on and so on. You can give stories upon stories and so on and so on. So in Kenya, I can say we have done relatively well with the 83 psychiatrists since the last graduation for a population of 42 million. That is one psychiatrist for over a million. And this ratio has been there for the last 15 years. Though we are putting in a lot of effort to train these psychiatrists, the ratio remains basically the same. And the interesting is that although people say we have done very well, every time I went to meetings, we have this number of psychiatrists, and I've been able to train about 97% of these 83. When I did an analysis later, I found that that was very highly deceptive. You will forgive me, I have a tendency of talking ahead of my slides. So there's a possibility that some of the things I'm telling you, they are covered down later on. We have a lack of financial resources because of poverty. Most people live on less than $1 a day. A lack of appropriate policies, even given the financial and human constraints that we have. Lack of evidence that a successful models that can be replicated in low middle-income countries. Lack of awareness by people on what mental illness is and what can be done about it. That is very low mental health literacy among health personnel and within communities. And here, when I'm talking about health personnel, I'm talking about doctors, I'm talking about nurses. We have data, which I may allude to as we go along, where we look at many health general facilities in Kenya, from health center all the way to Kenyatta National Hospital, the referral hospital where we train. And I can tell you that we found that about 70% of the patients admitted at Kenyatta General Hospital had actually a clinical depression if you look for it, and only in about 4% was the doctor suspect that possibly there could be a depression. So even among highly educated doctors, the literacy is very, very low. We just finished another study where we looked at oncology patients at Kenyatta National Hospital, and we found that most of the doctors, the oncologists that who are there, the doctors and the nurses, were on interest in the physical aspects, and more than 60% in depression, and nobody was looking at that. We are committing priorities of resources for HIV/AIDS and malaria, and a continued lack of vision and leadership that clearly focus on where we should be going and how to get there in relation to mental illness, given the resources that we have. And I have to say, given the resources that we have particularly human resources, because although we seem to be doing relatively well, most of these guys, the psychiatrists and the health professionals, are all located in Nairobi or Eldoret, where there is another medical school in the big urban area. So for us to dream of a situation where we will have the same ratio as is found in the Western setting is a pipe dream. It's not going to happen in the foreseeable future. There's a guy called Vikram Patel, whom some of you have heard about, and I remember attending a meeting with him in South Africa about 5 years ago, and it was put against the wall and say, as when do you think we will be able to catch up with what is happening in the West? And he gave very many reasons why it was not possible. But he said, I must put a timeline, then we are talking about 1,000 years. That was very dramatic way of saying, let's forget about that. Let's forget about achieving parity in terms of human resources, and let's concentrate on what we are capable of doing, given the resources that we have. I don't know, these are statistics that are very well known to you. I've just alluded to them. Mental health diseases, particularly depression, is achieving a very prominent, depression is achieving a prominent position in the leading causes of disease burden. In the developing countries where I come from, it is within the first 20, and it is rising very fast. And maybe in the very near future, in the foreseeable future, this case, it will launch by even a higher level. So, given all of those, there is need for action today. And I'm saying today, not tomorrow. Even given our social, cultural, and economic status, to do something, because the people, I say, the prevalence is the same. They are not going to wait until we have the resources. And they have the need. They are depressed, they are suicidal, they are hurting, they've gone through a lot of trauma, violence, and all kinds of things. We must do something now. And as we do whatever you want to do now, in my view, there are three very important areas that we must always keep in mind. What we give must be affordable. That is within prevailing economic status. That is affordable within the situation in which we are now. But more importantly, and this is where you guys come in, and all of us come in, that it must be appropriate, that is effective and evidence-based. So it's very important that we don't just offer services without evidence why for the effectiveness of those services. It must be available, that is, people can make an informed choice on whether to take them or not. At the moment, we have nothing, or maybe nothing, but I think I'm thinking of a situation where somebody can decide, I'm not going to look for a psychiatrist, and I'm not going to look for a clinical psychologist. I'm going to see my faith healer, who is always available next door, and I believe I am going to get something useful from that person. Or they can say, I'm going to see my traditional healer, but I know my traditional healer has some kind of knowledge, and it is going to be helpful to me. In fact, we have data that they can be very useful. We have a doctor from Kenya here, but allow me to say that some of the traditional healers that we dealt with are more informed on mental health than the doctors we are producing. Must be accessible, located within physical reach of the communities. We don't want a situation where people will have to travel 200, 300 miles, as I saw in Somalia, and other places just to get some help. These services must be such that if they want a service, they can walk with relatively short distance and access these services. Are these things possible? Yes, I think they are. Yes, I said I stopped ahead of my slides. Yes, there is hope that we can be achieved. This I feel that is realistic, but cause not only for innovation but also participatory involvement of all stakeholders in the communities. And if you allow me to pause there a little bit, stakeholders in the communities. These are not necessarily psychiatrists and the clinical psychology. You can actually forget about them. I have trained these doctors, and when I did an analysis about 2000, slightly more than 10 years ago, I was shocked at how little impact I was making in my own country. So we need to identify the stakeholders that matter in that country. It could be doctors if they are available, very important stakeholders. It could be equivalent of what we call physician assistants, for them clinical officers, nurses. I've just talked about traditional healers. I've talked about faith healers. I'm talking about teachers. I'm talking about opinion leaders, the gatekeepers, the people who decide if you go into a community. You may have the best, wonderful ideas, but unless those ideas are accepted within that culture and are within that culture and are appropriate within that culture, then you are really wasting time. I remember a big study, a big project, I think by WHO some time back, when they went to a community. There were lots of waterborne diseases because they didn't have toilet facilities, and they actually made latrines for the people. And they hoped that when they come back, people will be using them. When they came back to do an evaluation, they found them locked, and nobody was using them. And they decided to find out why it was. And the people said, our culture does not allow us to share toilets with our doctors. Okay? And they were just there, nobody was using them. And there are numerous examples where we think we know it well, and we do not take into account the cultural values, and those can be very important. So, taking on board the people who are custodians of the culture in that area we want to work, and telling them, and they accept what we are going to do, and they tell us the barriers that we may anticipate or may come along our way, I think is very, very important. And of course, through the global arena, through partnerships, and that's why I am here. We will talk about that and have the opportunity to talk about that. And making a very special plea to you, partners from USA are indispensable and highly desired. Let me say very clearly that I have come to this country to look only for one thing, not for money, but to look for your goodwill and the expertise that you have. Come and share that expertise with us. Your students will benefit, whether they are masters, PhD, postdocs, or even the members of the faculties who want to do research. They will work with our students who may be doing similar things. We have the infrastructure that will make these things possible. I've just been talking to some people about this. Everybody is a win-win situation. Your students get that experience that they want. They publish their papers. They will be registered in the home universities in their own countries. They get their degrees, and the country benefits. We get good research that is that's a kind of transformational research, and our students also benefit from interacting with our students. So together we can identify the opportunities and the challenges and work towards overcoming any barriers while maximizing on the opportunities. And if I was constrained with time, I would actually stop my presentation there, because this is the most important presentation. It is exactly for the above reason that African Mental Health Foundation exists, and the rest of my presentation is therefore about how African Mental Health Foundation hopes to achieve its main objectives and the mental health for all in Africa, with Kenya as a pilot. There are a few things that I'm going to do. For example, this information is available on our website, and I don't think I should spend a lot of time on that. But basically, we take a multidisciplinary, multi-sectorial approaches. I've already talked about that. Strategic partnership and alliances, continue developing our internal capacity and capabilities, because we are also thinking about sustainability. Sustainability beyond me. I think I've reached a stage where I'm not so much concerned about me, but I'm concerned about my students and tomorrow. Strictly adhering to our core values and ethical standards and conduct activities in a manner that safeguards the environmental conservancy. Now, I don't need to go into that because it's available in our website. But in a nutshell, having spent considerable time training at the University of Nairobi and more focused on churning out students, what we might call kind of laboratory medicine, with a little touch with what was happening in the community. We decided as we needed to think outside the box. There were several opportunities that came our way, some of them very, very most unfortunate opportunities. One of them being the 1998 bomb blast at the American Embassy. We were involved in response to thousands of people, hundreds of people. 1964, this is the 1994 in Kigali, we were involved, and we started learning how to respond to human suffering completely outside academic circles. In 2002, there was a big tragedy in one of the schools where 87 children were burned to death, and there was nobody to respond, and we didn't even have the resources, and not a single cent from the government, and we just mobilized people, and we were able to respond to that. So it's a combination of many things, as this information will be available in our website. I think I've already talked about this. And the stakeholders, mental health workers, psychiatrists, counseling, clinical psychologists, nurses, psychiatrists, social workers, informal lay mental health workers, faith healers, traditional community-based workers, recovering patients. Now, now that I'm here, let me just say something about the faith and traditional healers for a very short time. We have shortage of human resources, but we have no shortage of traditional healers. When I was talking to the chairperson or the president of the Traditional Healers Association, who has got a doctorate, by the way, from a university, from a German university, told me that they had about 20, not about the 20 registered traditional healers in Kenya. Those are the ones who are registered, recognized by the government. But she also said she knew that there were many, many more who were not registered. Faith healers, again, in plenty. These are the people who are consulted everywhere. So if we are able to work with those people, faith healers and traditional healers, will be getting very close to the people. And as I said, we done some work and we found that actually they can do something if we be properly guided. I want to say something about community-based workers, because I think they are very critical in our country. In Kenya, I didn't know this. I was just sitting in the university office doing research, turning out students interested in publication and things like that. But I have just learned, and I hope Steve here from Kenya will probably bear me out, that is, he himself has been able to get out of academic circles and go into the community, that out there in the Kenyan system and all this is so well structured that we are able to go down to the family level through these so-called community-based workers. And these people, for at a center which has got 1 or 2 nurses, okay, they are 50 to each one of those. In other words, if I'm sitting in a health center, I don't know how many are there will be about 50 people that are my link between me and the unit and the health and the families. They know the members of the family by name, they know their ages, they know what the father does, They know what the parents do. They know all the problems. They even know how many goals they have. They even know how many children they have. So they know them very well. And these are the people who are being used by the Ministry of Health to convey messages on issues like HIV, AIDS, good nutrition, and anything that you can think of. The only component they do not have is mental health. So there is a possibility that if we are able to engage with these people and work with them, there is every possibility, potentially, that we can reach every individual in the community. Of course, we realize that we need to work with social scientists, health economists, anthropologists, and the media. In fact, we have a media officer in our office. Other NGOs, community-based organizations, human rights groups, and civil organizations, human rights of patients with mental illness in Kenya was a very big issue and covered by the CNN. Communities and community leadership, including administrative, political leadership, policymakers, collaborators, partners, and so on, research to generate data to inform policy and the practice, and above all, with mental illness, people with mental illnesses and their families. These are the stakeholders. Talk about global mental health. We can talk about global mental health in terms of working across countries, but I also believe we can have kind of a global mental health within a country like Kenya, and we are in the process of doing that, and the results are very fascinating. I have talked about this. Let me just jump them. Now, let me show you some few photographs. This is a study we are doing at some places 250 miles southeast of Nairobi. This gentleman here is Dr. Kasakala. I was doing clinical psychology, got his doctorate. This is Abguayo, he got a doctorate. These are other people right in the community. You can see they are very poor people. They don't even have shoes. This guy here will be a very useful person in making connection and make connection with the rest of the community. Again, really not just don't want to repeat myself on some of these issues. So the external environment in which Africa currently operates, we are based in a low-income country. I'll say that in Africa is a significant achievement gap in spite of similar patterns of mental resources found in high-income countries, where limited allocation of financial resources for mental health by the government and the corporate community. Lack of an operational mental health policy is still in draft form and with inputs from us. And the violation of human rights of people with mental illness, I say it was it was covered in CNN. High level psychotrauma is a result of gender-based violence, sporadic, politically instigated violence. We just gone through great elections last month, and we were so pleasantly surprised. It was so peaceful during the election, and sometimes we say, why don't we have continued having this election so that we can thank you for the support that this country gave us. We have a new constitution which is modeled after the American Constitution, and thank you very much. You played a role. We have high influx of refugees and internally displaced persons. In Nairobi alone, there are over 300 Somali refugees and living in Nairobi, and from other countries. I've talked about high inadequate human resources and the inequitable distribution within a bias for urban areas, stigmatization, social exclusion of people with mental illness, other community. I've talked about all of this. So, as of now, that is the environment in which we are operating African Mental Health Foundation. Seems to be operating on. We also have the external environment also provides opportunities for mobilization of resources both in and out of the country to minimize the treatment gap in mental health. This can be achieved by addressing the challenge posed by external environment in the following ways, and here you can play a role. A professional-based informed intervention and support. I was talking to some people earlier in the morning, and I said the opportunities are there, and I even suggested areas that need research. I think reproductive health is very, very important. We are talking about pregnancy, the perinatal period up to the age of 5 years. The structures are there for following up these children. The only thing they lack is mental health. School mental health, very, very important. Like we got a grant from Grant Challenges Canada, and we are looking at the school mental health for the first time in kids between the ages of 6 and 13. There's something else we are doing with the European Union, looking at the substance abuse between 14 and 24. There's another thing we are doing with the University of Washington, St. Louis, on psychosis and so on. And that area, that age bracket is very, very important, because that's when the people are developing. And we want to see whether providing intervention at that early stage can prevent occurrence, the instance of psychiatric conditions. And then, of course, we have an emerging class of people who are getting old and with no services at home. And equally important, when we are talking about intervention, we are also talking about intervention at the health center level, going down to that level, the kind of intervention we are going to put in, whether cognitive behavioral therapy, whatever psychosocial intervention. As I said earlier on, we want to know whether what we are doing has a scientific basis, because we want to give appropriate intervention that work. We want to minimize stigma, increase awareness of the rights of people with mental illness and their legal capacity in terms of ability to make informed decisions and act on them. And it's a very good study. I was told even yesterday, and really almost brought me down, about what is happening in that place called Homa Bay, and the kind of things that are happening there to little girls is heartbreaking. Thanks to Duke University, through Eve and her group. And as I'm talking now, she's on her way to that place. Something is happening. Improve the social inclusion and economic participation, therefore breaking the vicious cycle of mental illness, poverty, and accelerate achievement of the Millennium Development Goals. Talk about social inclusion and economic participation, again, being demonstrated by staff from this university. However, we need research to provide evidence on the best way to address the various challenges. I have said that several times since I started talking, and I want to attempt to talk ahead of my slides. Research can be maximized through developing partnership locally and globally. For example, external partnership with established researchers and institutions who have the human and the financial resources through funding agencies, government agencies, and charities, that you can afford to send people to Africa. They may have grants, students, let them come and work with us. Let me just say something about government agencies and charities. We are working with some of them, but we have, for us, the government about 2 years ago, we were very surprised. The Minister of Health approached us and said, we want you to do research for us. We want you to do mental health research to inform our policies and practices. And they actually drafted the memorandum of understanding and asked us to have our inputs. And it was signed by the Minister for Health. And they gave us opportunity, said, you can go into any facilities in Kenya owned by the government and do research in that, if it's that research is going to help us. I think here they were not being very genuine. I think they were being very clever. we'll be able to send staff to your foundation so that they can work with you and you will pay them. Of course, we knew they didn't have anybody to send. But the other side of this, you can also send your own staff to come and work with us. I think that's what they were interested in. And we have no problem with that. So it is on this suggested approach that African Mental Health has based its hope for mental health for all in Africa. So that's the website. Very briefly about this, in short, we have these structures. Human structures to support the research, human structures in terms of supporting research administratively, financially, and so on. I'm so grateful to the Canadian organizations in Canada that gave us some money to develop our structures, to make it possible for us to do research. As I said, we have this memorandum of understanding. We are also working with several universities in Kenya. I think I'll be able to show you a photograph which was raised with the attendance of the Vice Chancellor, our rector, or the President of the University of Nairobi, and so on and so on. And we are in the process of developing modules and agreements of institutions in universities in Europe, USA, Canada, dealing with research, knowledge translation, and exchange, and plans. And I sincerely hope that we will be able to move that in that direction or to the UTM, University. I have found memories and good things about the Duke University. And I tell you, when we had the problem in America, the American Embassy, there was a Dr. Thielman who was posted to the American Embassy to oversee problems, mental health issues, and we established good relationships. He came to our foundation, he spent a lot of time with us, down to have a senior American diplomat, and he kept on telling me, I trained at the Duke University. Yes, we have covered this because I want to allow time for questions. This is the PhD colloquium. This gentleman here is the president of the University of Nairobi, the Vice Chancellor. This gentleman here was my student. I saw his PhD. This time he was the Deputy Vice Chancellor in charge of academic affairs. I don't know, Steve, whether you know that he has just been appointed the Cabinet Secretary for Education. Okay. This is the lady in charge of research at the University of Nairobi. This dean, I don't know who this gentleman is. This is came from Egerton University. This is the academic vice chancellor in charge of academic affairs at Egerton University. And all of these are my students, PhD. So this guy over here was visiting from University of Harvard University School of Economics. Okay. Now, who are these? This is like from this is the lady from Victoria, from the University of the School of Public Health and Hygiene. This is John from Beckerley University. And this is a student from Leeds University who was doing an internship with us. She's just working on her master's. She's just about to get it. And this is my PhD student now. She's being coached by another university. I'm very happy for her. And that's us at work. Let me not go into that. This information is available. We are working with the University of British Columbia to develop computer-based learning to train students on the research methods and so on and so on. So, I'd like to end there by saying Let me just tell you, this is a little bit, this is a cheetah. And this is an hyena. I think the hyena wanted to get a part of the cheetah's kill, and he was chased away. Because alone, the cheetah is except when the lion is around, the cheetah is the king. Now, these are monkeys, baboons. Baboon are the best delicacies for cheetahs. And a baboon alone is dead meat as far as the cheetah is concerned. But when the baboons get together, they were able to chase the hyena away. So all I can say is that just together, we can do it. Would you like to be part of our team? Thank you very much. Somebody is asked to control this.
Yes. So is psychiatry a popular career choice for medical students in Kenya?
No.
No.
No, it's not particularly popular, and even I, we are trying to do a study in that area. The Steve who is out there, and recently I was approached by the Royal College of Psychiatrists through the World Psychiatric Association, and we collected more data in 11 medical schools, all the way from West Africa down to East and Central Africa, down as far as Zambia. The only place we didn't go into was South Africa, because somebody else was doing that. And I've just been looking at the data, and it's amazing about the similarities. Basically, I think when they go to medical school, when these young people, they are very positive about mental health. But as they go through the training and they get in touch with the surgeons and the physicians and so on, I think that's where they get spoiled. But basically the patterns are the same, and when we look at them, they also the same as in this country. Yeah.
Claire. Early in your presentation, you were talking about that models that are used in the West are not easily replicated. And I was in lower income countries, and I was wondering, are you talking about models for treatment or for dissemination of mental health treatment? And then what is your foundation?
Let me make myself very clear on that. I think you have very successful models in this country. Okay, there's no doubt about that. Very successful models. But our problem is, we know those models are working in this country. But are we just going to relate to those models and then try to apply them in the current administration? And I'm saying, perhaps not just directly. We need to test them and see if they work. Fortunately for us, we don't have to struggle so much in inventing the wheel or inventing new models completely out of the blue. Why don't we take what we know has worked elsewhere, but let us not just apply it without testing it? And this is what I'm saying. Yes.
I did some work in Durban, South Africa, at the medical school last summer, and one of the psychiatrists there told me that one of the complications for them is that it was harder for people to distinguish the symptoms of schizophrenia from the clones of the ancestors. That people kind of have when people hear those voices, it could be either, and sometimes that becomes very complex, makes the role of the psychiatrist very complex. Does that correspond to any of your experience?
Well, I think it is when you talk about psychiatric symptoms, you can describe a psychiatric symptom that you are seeing. And you can also have a theory on how you interpret those symptoms that you are seeing. And I think that's where the difference is. And it's not just confined to people from Africa. And some of you may have heard of a guy called John Collins Carruthers. He worked in Kenya in 1947, and so he was And he came up with very interesting observations, like depression did not exist, and so and so on. The problem was, and I believe John Colin Carruthers was an extremely brilliant psychiatrist, but he did not know that symptoms, psychiatric symptoms, the interpretation of those psychiatric symptoms can be influenced by the culture in which the people live. So again, it's a question of not understanding the culture of people. People with the depression in Kenya, I'm coming to answer your question, would present with the physical symptoms. They come with headaches, pain in the chest, and all kinds of physical symptoms. And what do the physicians, as we are talking here today, what do? They keep on investigating and investigating. They do all kinds of things which are very expensive. And at the end of the day, you know what they tell them? They tell them, I don't think there's anything the matter with you. Maybe go back home and try to find out what is happening. What are they suggesting? Go back and look at go to the traditional healers. So they don't know. Many people do not know that you can hear a voice. We're talking about a human hallucination. And they have no medical explanation for it, because nobody has ever told them. They only use the construct that they are used to. So you can't blame them for thinking that since there is nobody is unusual to hear a voice that other people are not hearing, this must be supernatural. That's the way they have been brought up. So the mistake is not them. The mistake is us. We have not found a way of communicating with these people so that we give a different model. And even as scientists, initially we say schizophrenia is a biological condition. Then we got to know about the dopamine theory. And what are we doing with the more invention of imaging technology? We are going into neurotransmission, what is happening. We are looking at the hippocampus, we're looking at the ventricles. Even we are looking at the genetics. Even we, as scientists, there's still so much that we don't know, and we are still looking for an explanation. So it is either way, because you can only, you tend to explain on the basis of what is normal for you as a way of explaining things. So the answer is right. He was correct, 100% correct. But then the onus is on us to tell them, yes, it's okay. I understand what you are feeling, but there's also this other model. Could be because of this illness. And you explain to people that, and you give them very simple medicine like haloperidol, which is very highly affordable, and that sometimes the results are so remarkable. I'll give you an example. I was in Somalia some time back, and I went to the local hospital, and there was somebody who was chained at the request of the relatives, because he was making a lot of noise, he was violent, and there was nothing they could do. The doctors didn't know what to do, the relatives didn't know what to do, and the only way to maintain safety for everybody was to tie him. They also had haloperidol, but they didn't know that this was schizophrenic illness. So we asked them, we gave 5 milligrams of haloperidol, and within 5 days, we were there for about 2 weeks. This person was coma, and the symptoms subsided. In their own way of explaining things, they had also had their own way of explaining what I had done. Okay? This is a very powerful witch from Kenya. Because that's their model of explaining things. Yeah. And we spend a bit of time telling them this is a mental condition.
Thank you, Professor, for a very nice talk. I had a question. You spoke a bit about stigmatization in the community. But what about acceptance as your kind of fifth A, acceptance? How do people accept help for a psychiatric disorder? Do they accept help? Do they see it as something that needs help? how is that? I know that a lot of it is first educating them and their families, but what type of acceptance do you get as well?
I think once people know that they are dealing with the psychiatric conditions and they are treatable causes, they come forward for help. Okay. In our foundation, we have a clinical wing, and it's very busy. When we started, we had people coming to see us on at night. I think everybody comes. I think I've seen the whole range of social class people coming to see us, and they know that we are psychiatrists. So I think with a little bit of education, I think it's just mental health literacy. How we do it, I do not. I've been told, one of my most popular books, which has overtaken all the academic and scientific books that we have written, is a little book we call Your A to Z on Mental Health. And in this book, we explain in very simple language what is an hallucination. How come people can hear voices when there are no people? How come that people can talk on their own or start accusing neighbors of interfering with them or start being violent out of hallucinatory voices? And it's been, I think they printed about 3,000 copies and they sold out in about 1 year, and now they are on their second. In other words, there is thirst for information. Yes.
You were talking about mental health disorders sort of working their way up the burden of disease.
So talking about what?
The burden of disease and how mental health disorders were moving up the ladder of the burden of disease.
Yes, the burden of disease.
I was curious both how you identify
The burden.
the mental health burden of disease and what are the prominent disorders?
Don't ask me because I don't know. Because I cannot know everything. But there are health economists who are very good at this. I just shown you this guy from Harvard who was visiting with us, a postdoc in health economics. And these are some of the issues that they are looking at. And there are people who specialize in this. Why don't you let them do their job? There are ways of doing this. And WHO, World Health Organization, is very good at this.